I'd now like to welcome Callan Roberts, who is a physiotherapist working in Anglicare. He's going to talk about allied health under the ANAC, and this is a case study, so thanks Callan.
And thank you, Lorraine. All right, we're working. So I'm going to talk a little bit this afternoon about the recent funding model changes in aged care, residential aged care, how they've affected allied health, and an example and some information on how Anglicare has developed some evidence-based exercise programs in response to that. You're going to notice a little bit of overlap with some of what Jenny covered, but I think you'll notice also that my presentation style is a little different, so I think it'll be all right. I'd like to start by also just personally acknowledging the traditional owners of the land on which we're gathered today, the Gadigal people of the Eora Nation, and pay my deepest respects to elders past and present. I'd also like to extend that respect to any First Nations people who are listening to the audience at the moment. I found this fact as well pretty interesting and also very sad that in 2020, 2021, Indigenous Australians were 1.4 times more likely than non-Indigenous Australians to be hospitalised due to a fall injury. And I really hope that as a professional community, we can make some pretty swift progress on closing that gap. All right, so October 1st last year was a pretty important day in the world of aged care. And it wasn't because Julie Andrews turned 87. And it wasn't because former US President Jimmy Carter turned 98. No, this was the day that the Australian National Aged Care Classification Model came into being and threw ACFI out the window. And although this change was long overdue, it was met with a mix of concern and cautiously optimistic delight amongst allied health professionals because aside from securing our jobs for the last 13 years, ACFI placed incredibly restrictive limitations on our scope of practice, and surely anything would be better than that. So I assume that most of you don't need me to elaborate on this point, but for anyone that wasn't aware or isn't aware, ACFI incentivised aged care facilities to have us allied health professionals performing massage or technical equipment, pain management 4 days a week on a consistent basis, on an ongoing basis, to as many people as possible, because this would generate a significant amount of funding that they use for things like staffing. And as a result, I don't know about you, but I felt a bit like a tertiary educated cash cow, running from room to room, providing treatments that basically did nothing, and that left almost no time to implement actual evidence-based interventions for things like exercise, for falls prevention, even when we saw a gaping clinical need. Now that's not to say there was no exercise in aged care under ACFI, there was, it just wasn't the focus that it always should have been, and I think we knew deep down it should have been. And that not only led to suboptimal health outcomes for our residents and a whole bunch of unethical practices, but a lot of our colleagues have left the sector altogether, and that's a really sad outcome too. To those of you that stuck it out though, I think you deserve congratulations, because the dark ages are over and the renaissance is here, because ANAC is completely different to ACFI. So in a nutshell, like its predecessor, ANAC allocates funding to consumers along with care minutes based on their care needs. But unlike ACFI, this is not contingent on anything. Aged care facilities and the consumers get the funding regardless of whether any specific intervention is provided or by any specific person. And this small but significant difference really has opened up a whole new world for allied health in residential aged care. And I understood from rumours, but I'm hearing today as well that different aged care providers have responded in different ways, not all of them good. But I'm happy to stand before you and say that Anglicare, which is where I work as a sole trader, really did see ANAC as a golden opportunity to get us allied health professionals back to evidence-based practice with a focus on reablement and rehabilitation, which is exactly what the Aged Care Royal Commission wanted us to do in its final report summary a couple of years ago. So with that, a small working group has got together to reimagine what allied health could look like in residential aged care in a post-ACFI world. We first thought there'd be a need to review each of our residents, taking a broader look at their clinical needs and impairments, consider all available interventions, and discuss these with the resident before developing a person-centred plan to achieve their goals. We also assumed that things would naturally move away from a focus on passive treatments, manual therapies, towards an exercise-based approach, because that's where the evidence was. And although we thought that we'd still need to offer a range of different settings to deliver our treatments to meet different people's needs and preferences, we hoped that there'd be an increased uptake in group activities, group exercises, because they were A, more efficient, and B, proven to be effective by research, not the least of which was Jenny's now infamous Sunbeam trial, which you've all just heard about. In fact, we were so inspired by Jenny's trial that we decided to take the key principles, even though we didn't have her high-tech equipment, and try and adapt them to implement them to create some programs in our own homes. And the result of this process was our wellness and reablement program. That's what we've called it. And basically, it's a suite of exercises, evidence-based exercises that are intended to cater to all levels of ability. So over on the left, you've got the reablement side of things. And the aim of this, as you can see, is to improve strength and balance to minimize risk and rate of falls. To achieve this, we've developed a tiered system. On the bottom is a cohort of people we work with one-on-one. This feeds into an intermediate group, which we've given the ultra-sexy anti-stigma name Strength and Balance Group 1. And that feeds into the advanced group, Strength and Balance Group 2. Over on the right, we have the wellness side of things, starting with the wellness group, which is a standalone exercise class not related to the other ones. And we've designed that to be as inclusive as possible. The aim of it to provide enjoyment, socialization, as well as hopefully promoting some light range of motion and strength. Also under the wellness umbrella, we've got a range of exercise-based activities. I'm sure your guys' homes have them as well. Think balloon tennis, seated tai chi, carpet bowls, things like that. Fair warning, so we're going to dive a little deeper into each part of the programs. There's quite a bit of text on the next few slides, so just bear with me, I'll point out the important things, and if anyone wants the detail, you can tap me on the shoulder after I can get the slides to you. So the wellness program, or the wellness group, first of all, we've set a class size guide of 20 to 30 people. It's run by a physio assistant, preferably in a big communal space, for around 30 minutes, 1 to 2 times a week. They're doing moderate to high rep ranges and a Borg intensity scale of light to somewhat hard. Because we're trying to make this class as inclusive as possible, we've listed most things in the precaution category. And as you can see, the only things that are going to exclude someone's involvement outright is respiratory or gastro symptoms and a positive RAT or PCR in the last 7 days, because God knows we couldn't deal with another COVID outbreak. In terms of the program itself, you've got a 5-minute warm-up roughly, going through these gentle exercises before going into a 25-minute main part. And those exercises go through all the major muscle groups, and they can be done in seating or standing, depending on the resident's ability. The other thing to note here is that because the main objective of this program is enjoyment, not necessarily improvement, that we don't require progressive overload. But obviously, if people are improving, the therapist identifies that they can move things along, then they absolutely can. On the reablement side of things, so again, thinking about the pyramid, we're on the bottom with the one-on-ones. And although this isn't a group class per se, it is a really important part of the reablement program because it allows us to deliver those really person-centered interventions aimed at the resident's specific goals. It also helps us establish those minimum baseline requirements of range of motion, strength, balance, that unlock their participation in the intermediate and advanced groups. And which would be great because they are more efficient and more effective, potentially. Clicker, there we go. So although we would love to work with everyone as many times as we can, our time is limited, so we have to prioritize. As you can see, we developed a rough guide list of who we want to work with one-on-one. But at the end of the day, if someone doesn't fit in one of these boxes and they really want one-on-one for whatever reason, of course, we're going to try and accommodate that. So once people have developed that foundational strength and balance and they're ready to join one of the group classes, we encourage them to do so. Although they are separate classes, the intermediate and the advanced group are very similar in the way that they're structured. So we're going to go through them side by side, and I'll just tease apart the key differences. First of all, to the aim, basically the same for both groups, but they differ in terms of who they're suitable for. As you could expect, The intermediate group is more suitable for people with lower levels of strength, balance, range of motion, and people engaging in that group can have any level of falls risk. Whereas in the advanced group, they're going to require higher levels of strength, balance, and range of motion, and it's not suitable for people who are at high risk of falls. That's just a line we drew at the time. Might be subject to review in the future. As a matter of fact, again, the only difference between the contraindications and the precautions for both groups is that you can see high falls risk is a precaution in the intermediate group and it's a contraindication in the advanced. They might be able to enter into the intermediate group. Was that a contraindication? It was. Well, these are guidelines, and the thing that I've left out here is that we really did emphasise for our clinicians to use their clinical judgment. So like these are guidelines, and at the end of the day, you know your residents best. So if you think someone can participate, absolutely, yeah. Good question though. Resources required, basically the same for both groups. The physio is leading both of these groups, assisted by a physio assistant. Location, class size, frequency, duration, all of this stuff is the same for both groups. Rep ranges are guidelines only, as Jenny suggested in her study. They're going to be individually set and also progressed. The progression model we used is actually plucked straight from the Sunbeam trial because it was proven effective and why I fix what ain't broken. In terms of the programs themselves, as you can see, warm-up, similar or the same for both exercises. Naturally, the intermediate group is going to be a little less challenging than the advanced group. The static balance and strength component for both groups is the same. You can see they do them for slightly different amounts of time. The key difference here, as you can see, is that the advanced group does a challenging dynamic balance component and the intermediate group does not. I've got some photos of my residents. I'll come back to those if I've got some time. I just want to get through a couple more text slides first. Naturally, we've encountered some common limitations and challenges in our programs. I could probably spend the next 15 minutes talking about all these, but the one that frustrates me the most is point number 2, because personally, the programs are really designed for a situation where you've got a physio or an allied health professional working alongside an assistant. So the homes that don't have that set up, like mine, are really a little bit limited in terms of how effectively we can implement the programs and to how many people. And obviously that's going to impact results. Speaking of results, Lillian is one of our pin-up girls. She loves going to exercises and she's become a lot less mobile. She hasn't had a single fall. And that is also good news. So we're still collecting the data on all of our homes and trying to pull that all together. So I can't speak on that right now. In my home specifically, early signs have been encouraging. So particularly the last point, which is that the people who are engaging in these exercise programs seem to be having far fewer falls than the people that don't. 11 out of 263 falls in the last 6 months. Now obviously, that's going to be influenced by a range of different factors, but still it's a nice thing to see. It's a nice little correlation. I'd love to see that total number come down substantially. COVID has been a particular challenge in this respect, but I think it stands to reason that if we can get more people involved in the exercise groups, get more human resources, maybe we can see that number come down. So in summary, ANAC really has opened up a whole new world for us allied health professionals in residential aged care, and we can finally get back to exercise, reablement and rehabilitation. Not only is there a growing body of literature that supports this change, I've hopefully demonstrated that it really is possible for aged care providers to implement this on a grassroots level to promote falls and independence in your residents. Thank you. Question? Yeah. Absolutely. Yeah. In a post-ACFI world, do not discriminate between people who are there for a short. Yeah. Absolutely. Yeah, I definitely not anymore. Like a person is a person. Yeah. I'm at Elizabeth Lodge in Rushcutters Bay. Yeah. Thanks.
She'll be in touch.
All right.
I bet she's be in touch with you now. Thank you. Very encouraging. That question about respite is really important because we know that sometimes they decondition. It is a big problem, respite. So those of you who are working who can encourage a respite people to be involved in as well, that's to be encouraged where we can, I think. So thanks for that, Carlin. It's great to see how work is progressing and picking up on the work that you've been doing too as well, Jenny. I'd now like to introduce Cameron Boyd. Cameron's the lead for active lifestyle physiotherapy. He's going to be talking about fall prevention in residential aged care, at twilight aged care, the top-up study implementation. So thanks, Cameron.
Yeah, perfect. Thanks. So my name's Cameron. I'm a physiotherapist who's been working within the aged care sector for about the last 10 years. And I've really thoroughly enjoyed my time within the aged care environment. Previously, I had been working with elite sports teams, but have found my calling in aged care where you can have a bigger impact on each and every individual. So I've had the pleasure of working with Twilight for about the last 10 years. Had a limited involvement initially, just helping out with a couple of local residents with new family members, and obviously built up a good relationship over the time since then. We currently have 2 private practices and operate across 5 residential aged care facilities in northern Sydney. Twilight's got a long history of providing aged care in northern Sydney and currently operates 5 residential aged care facilities, each of which is around 44 beds, which allows us to provide very sort of focused and tailored care to each and every individual. At the end of last year, obviously, with the commencement of ANAC, we had an opportunity to partner with Rick Dawson from the Musculoskeletal Institute of Health, who is conducting a study on how physiotherapy telehealth can support older people to improve their mobility and reduce their falls using iPads or other similar devices, predominantly in the community, but we've had the opportunity to implement it in a residential aged care facility. So as we've all talked about already, 2022 was a transitionary year for residential aged care. So it obviously saw the commencement of ANAC, which provided a huge opportunity, as a couple of the speakers have already touched on today, to really get back down to do what we can do best as physios, and that's provide evidence-based interventions to help them each reach their individual goals. So obviously, in conjunction with the Clinical Governance Committee of Twilight, we sat down and we sort of nutted out a little bit of what we can do as physios, and had this opportunity to work alongside Rick with his great research that he's conducting at the moment, implementing the top-up trial across the whole of regional and remote areas. It provided a great opportunity for us to really provide an evidence-based program in a group-based setting to the residents of each of the homes we work with. So just touching on the specific details of the top-up study, it is a study like similar to the ones we've already discussed today, where there was a couple of eligibility requirements. Obviously, it did exclude residents with severe cognitive impairments and also those with severe physical impairments. So similar to what we had with Cal, some residents who are not able to weight bear were unfortunately excluded, which has been a little bit sort of difficult to navigate in some settings. The intervention is a 26-week group program that's focused on strength and balance. It's a tailored program for each individual resident, as well as obviously the video intervention. It works on a moderate intensity with a maximum of 5 residents per group. Because it is a telehealth design protocol, it is actually designed to be delivered by an allied health assistant or even the care worker within the aged care home. So it allows it to be rolled out across a much larger group of people. We've had the benefit actually ourselves of being very closely involved as a physio, and just from some discussions with Rick, he's very keen to hear the feedback on what the residents have felt in terms of coming from the physio versus the care staff. The one thing that obviously some of the other ones we've talked about required a lot of advanced specialised equipment and space. Some of the homes that we work in don't have the space to allow us to set up a proper functional rehab gym, which would be obviously ideal. The good thing with the top-up study, it's a very limited cost to get it commenced. Obviously, you just need some TheraBands and some ankle weights, which you can purchase very cheaply. But it does also focus on running through a number of videos that have progressive exercise videos that we can obviously work through foundation levels and then move people through as we run through the program. So the videos all feature Rick himself, and the residents love Rick and his presentation style. And those of you who know Rick, is like a very engaging guy with a huge amount of knowledge, and the residents, you can see their eyes light up when he comes on the screen, which is great to see. So obviously in our setting, we're working alongside the residents. The good thing is it did allow us to include a couple of people whose mobility is probably a bit more limited, that in a community setting may not have been able to participate in the higher level balance exercises. The results will be published for the top-up study in 2024, but from discussions with Rick, and my understanding is things are like going quite well across the whole of the study. In our particular setting, we've had some fantastic feedback as well, so I'm really looking forward to seeing those results next year. We'll just go over a little bit about the actual top-up study. So it involves a physio screening, which is conducted via Zoom. Within this screening, we obviously set some individualised goals, as well as provide some health coaching, like we talked about how important it is earlier today. We then do 2 group exercise classes per week at each home, and these run for about 45 minutes to an hour. So obviously that's getting up towards the optimal exercise prescription. After some of what we heard this morning, I think we could possibly add in a third one and try and push people along a little bit more. The primary focus of these exercise groups is on balance and strength exercises, and they're, like I've already touched on before, we do get support provided to us from the care staff or the recreational activities officer, it's also a great opportunity for them to develop their skills, because I know that they have been traditionally running the exercise classes and sometimes with limited support. So just got a couple of pictures here of just a typical setup at one of the homes. So I took this a couple of weeks ago. So you can see one of our team members, Ryan, is obviously doing a bit of a demo as well. But in reality, having the video, like in opposite to what Cal was saying, where it's sometimes hard for him on his own if he's demonstrating and then trying to support people, having the video also allows us to go and help those residents that might need a little bit more hands-on assistance. And it's worked really, really well. So the residents have been very compliant. Probably the one challenge we've had being a randomised controlled trial is when you've got people randomised into, like what Jeannie touched on as well, you get someone who's been super keen from the initial screening to do the program, gets put into the control group. And obviously being a small facility, and those cognitively aware residents all talk at morning tea and lunchtime, so we've had difficulties keeping them apart. So that's probably the only thing that has been a little bit more challenging, but we've worked around it. We've found a small space where we can go away and secretly do the exercises, and the others are all looking forward to starting in 6 months. It is a little bit, yeah, you feel bad because there's some that you know would really benefit them. So we're kind of looking forward to the end of the trial period where we can roll it out more broadly like what they're doing at Anglicare. So just got a couple of residents that have had fantastic results with the program. So there's a lady who's called Audrey who has been living at one of the Twilight homes for about 5 years. She's been participating in the study since it started about 4 months ago, and she's reported herself that she's been really enjoying the exercises and that she's really found that the weights, so initially we didn't have some of the equipment, as soon as within a week or two, adding in the ankle weights and a couple of other resistance exercises, she's really found it helped her a lot. Recently, she actually had a family member sent a lovely email to the facility manager and CEO of the company to say how thrilled they were that they saw her dancing at her granddaughter's wedding, and were just surprised at how well she was really doing, which is obviously great to hear. That's what all of us as physios want to be, sort of having that impact or effect. Another resident, Liz, who's also been part of the top-up program, has reported having a huge improvement in her gait and feels much more steady while she is walking. So obviously this is all just verbal feedback, but what we do look forward to is seeing the actual results that Rick will be publishing at a later time. The really good thing is it presents a number of opportunities. So we've had a couple of people from rural areas discuss how it's difficult to get allied health in those areas. It provides like Sydney-based services such as ourselves or other providers the opportunity to share some of these technologies with the wider communities. This can obviously improve the residents' health and wellbeing. It can also really improve the residents' and the family's satisfaction within the aged care system, which is obviously a key thing for all of us. It also provides us the opportunity to implement a sustainable and cost-effective service model of physiotherapy, because you can obviously have a low entry of not a huge equipment requirement, but also provide something that it does show a good effect at obviously falls reduction and improved mobility. If anyone's got any questions, by all means feel free to touch base with me later, and look forward to hearing the rest of the presentations for the day.
Thanks, Cameron. I have to declare an interest because I have a relationship voluntarily as chair of the board for Twilight Aged Care, and I did invite and have a discussion with Rick, and then had a conversation with Cameron as to what we could do to improve outcomes for the residents at Twilight. And can I just ask, go and talk to Liz, because the CEO reported last night he took them to the races yesterday. And Liz was there, and you hear her story. I won't tell it. I think it's a private story she needs to tell you. So it's very encouraging. I know Liz, and it's just so wonderful to see these improvements with people as they are being involved. And I'm so grateful we've got our health professionals, like our physios and our OTs and our nursing staff, who are so motivated. It brings tears to my eyes around improving outcomes for older people. And so encouraged by it. And I just wish and hope that we can actually get these messages to the work that we do within acute care, because I think you've got a lot to teach our staff in acute care about how we drive improvements in understanding older people. So it's not necessarily the delivery of the exercise, but just how motivated and caring you are and what you are delivering and the great results that you're seeing. So well done and congratulations. I can't help myself but acknowledge those things. I think it's wonderful.